I'll get started with some background information on our nonprofit here. My name is Twin. It sounds like twin sister, and I am the Community Health Resource Center Program Manager. You can see my information on the screen here. A little bit of background here. So Community Health Resource Center is a nonprofit 501c organization, and it's an affiliate of California Pacific Medical Center. We have been around for over 30 years, and our four main areas of service are behavioral health services, nutrition counseling, health screenings, and health education, which includes this lecture today. For behavioral health services and nutrition counseling, we accept appointments virtually right now. So if you have any questions about that, feel free to contact me. If you'd like to support our nonprofit and more programs like this, there will be a feedback form at the end that you'll get via email, and you'll also see on the screen that you can help us with. You can also donate to us directly. And lastly, you can check for our updates on all of our social media platforms. We're at CHRC-SF. And then before I forget, we have an upcoming class series in 2 weeks. It's called Chronic Kidney Disease and Nutrition. It's led by one of our registered dietitians, Elena Zidaru. And the information you see on the screen here will also be shared in a post-event email that you'll get after today's lecture. So I'd like to take the moment now to introduce our speaker, Dr. Milana Dolezal. She is a board-certified oncologist and hematologist who treats women's breast and gynecologic cancers, along with gastrointestinal cancers. She is currently the director of cancer survivorship and supportive care services, and her philosophy around care involves the power of exercise and positive thinking. I'd also like to add there that Dr. Dolezal rode her bike across the US with fellow riders, including Lance Armstrong, to promote awareness about the importance of clinical trial participation. I'll stop my share screen now and let Dr. Dolezal take it over.
Okay, thank you so much. Let me share my screen and get my slides uploaded. Thanks everybody for joining. Thanks for the generous introduction. I think hopefully everybody can hear me well enough. So yeah, today I'm going to talk about cancer survivorship and cancer thrivership. I like to think it more about quality of life, symptom management, and how can we strive and thrive in terms of your new baseline as cancer survivors. I'm going to talk specifically in that context about the impact of exercise and specifically weight loss and reducing your risk of recurrence and what is all the data out there. I am our Director of Cancer Survivorship and Supportive Care Services. So this is in my wheelhouse. I do have to admit, Twin noted the ride across country, and I'm an avid cyclist. Some people have seen me riding my bike to work and that kind of stuff. But this was a bit challenging for me in terms of kind of wrapping my head around the data. You know, of course, I think exercise is wonderful, makes you feel good, decreases cortisol levels, helps with stress reduction. But what's the actual data in terms of what's the evidence base here? So that's really what I'm going to try and focus on today here. So looks like we already have a question, but why don't we take a break for a second and just make sure that everybody technically is okay. So Twin, do you want to just make sure that Mary Lou's okay?
Yeah, so I will go ahead and unmute Mary Lou on my side. Mary Lou, if you have any questions that you'd like to ask us out loud before we get started, let me know. You can unmute your side.
No, I'm good. Thank you. I just appreciate Dr. Dolezal being here. Thank you.
Awesome.
Okay.
Thank you.
All right. Thanks so much. Okay. So that's sort of my introduction. Let's see. Here we go. Okay. So to the tune of what I was alluding to cancer thrivership, you know, really health risks have changed. And what does cancer survivorship even mean? And where did this concept come? So this little piece of magazine here is actually a seminal article And this was called Cancer Patient to Cancer Survivor, Lost in Transition. This was from the Institute of Medicine back in 2006. And the history is actually pretty interesting. This was after Hurricane Katrina in 2005. And a lot of the medical records at Charity Hospital in New Orleans were lost. And a lot of patients didn't know much about their history. You know, this is really before the electronic medical record and the information sharing. And so the idea was, okay, could you have sort of a suitcase in terms of, well, what kind of cancer did you have? What stage was it at? What does your surveillance need to be moving forward? What are your health risks? Are you at risk for heart side effects from maybe your treatments? All these sorts of things. So that's when the Institute of Medicine really started to think about cancer survivors and what are their unique needs and what are the health issues that we need to address. And here's a quote here that says, many people finish their primary treatment for cancer unaware of their heightened risk and really ill prepared to manage their future healthcare needs. And part of that also has to do with, you know, when you're going through your cancer treatments, you have a lot of appointments. You've got nurses, you've got nurse practitioners, you've got chemo infusion nurses, you have this whole team that's helping you. And then at some point, you know, that stops. Maybe we take out a port. And then I say, okay, I'll see you in 4 to 6 months. And it's kind of like, what? You've been seeing me every week or every 3 weeks or every 4 weeks. And that's really anxiety provoking. So just want to acknowledge that out there for all of the survivors that are managing that aspect of their care. But really the end of the treatment doesn't mean the end of the experience. 20 million cancer survivors living in the US, growing numbers. People are living longer and they're living with cancer either as a chronic disease or side effects from treatment as a chronic disease. And their unique needs are imperative. There's a lot of toll taken by cancer and its treatment. And this is not only on your physical health, this might be neuropathy, you might be dealing with prolonged side effects from anti-estrogen treatment. And really that can impact your quality of life and your sense of well-being. And sometimes these treatments have short-term side effects. Sometimes they have long-lasting side effects or side effects that might arise 10 or 15 years later. Personal relationships change, and really the survivor's care is altered forever. And this is just an example here to outline, you know, well, what about age match controls and, you know, my 65-year-old friend compared to me as a cancer survivor. So this is a really interesting study looking at the burden of illness and sort of what comes up to the top in terms of side effects or body health. And so arthritis symptoms, rheumatic kind of stuff, and that could be independent of being on a aromatase inhibitor or an anti-estrogen compared to age match control. So this is not a 65-year-old versus a 20-year-old, okay? Back, neck problems, certainly bone issues, and that could be joint injuries, that could be osteopenia, osteoporosis. We know a lot of those drugs have side effects, heart issues, strokes, high blood pressure, lungs, breathing problems, etc. And this looks specific at childhood cancer survivors compared to siblings. And then you can see some of these heart side effects bubble up, and we can kind of keep that in mind in terms of the symptoms that you're having and long-term health issues. So you have this idea of a cancer control continuum, so focusing on prevention. So what can we do? You know, so you have this cancer diagnosis, but what else could we prevent? Decreasing alcohol use, getting your screening colonoscopies, quitting smoking. So that's part of that prevention piece too. Early detection, diagnosis, treatment, and then we're really in this sort of survivorship piece in terms of a lot of the long-term side effects and coping. So health risks, again, have changed. So in terms of our American Society of Oncology, ASCO issued a position paper to talk about the reducing the impact of obesity on cancer. We do know that obesity is linked to several cancer types, not only breast cancer, but colon and rectal cancer. We see that from Asian patients who move to Hawaii and then move to the US, and their colorectal cancer incidence increases. And we're doing screening colonoscopies in people at 50 because of risk reduction and prevention. And cancer survivors are really more likely to experience fatigue, muscle mass, strength issues, heart disease, strokes, metabolic syndromes, all of these things, and also at risk of secondary cancers. So my focus is talk about what can we do in terms of intervention. Okay. And so there's another algorithm here that I like. This is Patty Gans at UCLA, who is a mentor of mine, and she really talks a lot about the 3 Ps: palliation, prevention, and health promotion. So you've gone through this trajectory. Now we're talking about quality of life, medical outcomes, and recurrence risks and secondary cancers. So what about obesity and breast cancer specifically? So I see a lot of breast cancer patients. That's a passion of mine. So what is overweight? What's obese? How do we even characterize these things? What are some of the definitions? So having a body mass index, which is a combination of weight and height, higher than 25 is overweight versus obese is greater than or equal to 30. Normal BMI is considered about 18 to almost 25. Unfortunately, a lot of women in the US are overweight, 66%. So there's a lot of implications in terms of that. Higher risk of being diagnosed with breast cancer compared to women who have a healthy weight, especially in postmenopausal women. I'll show you some of that data. And then being overweight can increase the risk of breast cancer coming back, so recurrence. So how are obesity and breast cancer specifically connected? So fat cells make hormones such as estrogen, essentially from cholesterol as a building block. And I've talked to some patients who are on aromatase inhibitors about how those drugs work. Obese postmenopausal women have higher blood concentrations of circulating estradiol and estradiol. Even if your ovaries are not functioning anymore and you're postmenopausal, there's lower concentrations of those sex hormone binding proteins. So you have more free hormones around in your blood and bodily circulation. More fat cells mean more estrogen that could make hormone positive types of breast cancers grow. Obesity, especially in here, this sort of belly fat, can be characterized by androgen excess, increased circulating insulin, insulin-like growth factor, which has implications potentially in cancer signaling. And fat tissues make these types of growth factors, which are expressed in breast tumor cells. They can be linked to increased aromatase activity. Sorry for the typo. I typed these all myself. And finally, extra fat cells can cause some inflammation, and chronic inflammation can be linked to higher breast cancer recurrence. And this just shows you here, this is Chabowski. He's done a lot of research in this area that, women who are obese have all these hormones and sex hormone binding globulin increased versus weight loss in these patients. You can actually measure some of these. There's an ultrasensitive estradiol test, and you can see some of the differences here. So what about exercise? What's effects of exercise on hormones? So we've shown that observational studies have shown associations with hormone levels and exercise in postmenopausal women. So you can have decrease in your circulating estrogen and androgens compared to sedentary women. And, this is a little all over the map. And that's one of my challenges here in trying to harness all this information together in terms of, there's conflicting studies, there's a lot of confounding variables, these sorts of things. And I also wonder too, not only in terms of, breast cancer specific estrogen types of blood levels, but I think one of the reasons exercise is wonderful is it's a big stress release, and part of it can decrease your cortisol levels, which is a stress hormone. So I also wonder about that. So that's why I put the cortisol level there in question marks. Okay, so what about distinguishing between your risk of getting breast cancer versus I already had breast cancer and now what can I do about it? Okay, so I think a lot of the people on the call probably want to know about that, but I do want to take a little bit of a step back and just evaluate what we do and don't know. So you might be familiar with the Large Women Health Initiative, the WHI. This was about 160 160,000 women. They were all postmenopausal, age 50 to 70, and they joined back in the 90s, but none of them had breast cancer when they joined. Okay, so some of them were nurses, etc. And the aim was really to try and determine if there's links between lifestyle factors, diet, exercise, and health problems like cancer. So at baseline, the height and weight were measured, and then again at a 3-year time point. At baseline, people in this study, 25% obese, I defined what that was, 34% overweight, and about 41% healthy weight. And there was almost 12 years of follow-up, and over 3,000 women during that time period who were postmenopausal were diagnosed with breast cancer. Now, this was a retrospective type of analysis as a look back. But what were some of the findings? And Chabowski presented some of this data at our San Antonio Breast Cancer Conference in 2017. This is an observational study, obviously, and Melinda Irwin over at Yale has done a lot of work on this as well. So at least a 5% body weight loss within 3 years of follow-up corresponded to decreased breast cancer risk by about 12%. That's about 10 pounds on average. And this was, lower breast cancer risk compared with women who didn't lose weight. And it was sort of irrespective of, are they really dieting? Are they watching their fat? How much exercise are they doing? So irrespective of intentional or unintentional weight loss. And it also seemed if there was a higher percentage of body weight loss, that there was a higher reduction in breast cancer risk. And this was comparable to women with stable weight. So that sort of sets the stage of some of the data out there that says postmenopausal obesity is a risk factor for breast cancer. Okay. And so this just shows, this is a table from the WHI that shows you in terms of weight loss, about 5%. That was your 12% risk reduction specifically in your breast cancer incidence. So getting breast cancer. There's a lot of other studies. I'm not going to go through this whole busy slide, but just know that, this has been evaluated and sort of validated as well as we can, unable to control for confounding variables, etc. So a meta-analysis of over 1,000 epidemiologic studies. And this was a working group published in the New England Journal of Medicine. There was sort of the European version of the WHI, which was this EPIC Panacea study, which was the European Prospective Investigational Cancer and Nutrition Study. That's a mouthful. Over 200,000 women, similarly, WHI, over 3,000 women diagnosed with breast cancer. Incidence-wise, this was over 4,000 women in a shorter amount of follow-up. And it did seem that a higher weight gain, so anywhere between 1 to 5 kilograms, so certainly, some 10 plus pound weight gains, higher, slightly higher breast cancer risk. And again, I mentioned confounding factors. There's lifestyle factors like current or prior hormonal therapy, birth control, hormone replacement therapy, especially for some of our lobular cancers. Alcohol consumption can also contribute to breast cancer development. So to be continued in terms of kind of what are some of the trials out there. There's 2 big trials, the WIN study and the WHEEL study. You can see the acronym there, conflicting data in terms of specifically looking at diet. So low fat, high veggies, high fiber types of diet. The WHEEL study said no benefit by changing diet. And these patients really hadn't lost much weight. Contradictory to the WIN study, Women's Interventional Nutrition Study, low fat diet benefit only really in the estrogen negative cancers, which is sort of interesting. But if there was at least a 2.7 kilogram weight loss, there was a breast cancer recurrence reduction. So I think what that sort of hints is that maybe it's not the diet itself as much, but maybe it's more related to weight loss. So there is this Be Well study. I've put some patients on it. This is the Breast Cancer Weight Loss Alliance trial. It just closed a few months ago to enrollment because they achieved at least the 3,000 plus patients they wanted. And this is a phase 3, large randomized 1-to-1 types of clinical trial. These patients have early breast cancer, but a little bit of a higher risk, stage 2, stage 3, and they're premenopausal and postmenopausal, and they have a higher BMI. And looking specifically at whether a telephone intervention base, looking at weight loss, so a structured program versus not, what does that do in terms of breast cancer recurrence rates in patients who already have a stage 2 or stage 3 diagnosis of breast cancer? Now, it does exclude HER2 positive patients, so this is a HER2 negative study. Okay. So, I presented a lot of data talking about pre and post diagnosis. Is it diet? Is it weight loss? Is it exercise? Is it physical activity? Is it both? So I've alluded to some of the inconsistent data that I just outlined for you. It's also limited. Some of the studies are limited by data capture. They're limited by other uncontrolled variables. Use of anti-inflammatories, possibly diabetic concomitant medications, maybe decreasing metformin, decreasing insulin growth factor, etc. There's, in terms of the pre-breast cancer diagnosis, a large meta-analysis showing essentially physical activity decreasing your risk of all-cause mortality, but maybe not specifically for breast cancer mortality. So what that means is, maybe your breast cancer is not going to recur if you exercise, diet, both, lose weight, but you might not die of a heart attack, or your diabetes might not have secondary complications. So that's what that all-cause mortality is referring to, possibly death or other comorbidities. You can see the other data here. When you look at post-diagnosis for breast cancer, big study showing sort of a 41% decreased risk in terms of all-cause death, and specifically looking at breast cancer, about 34%. So I don't expect you guys to understand what all these numbers mean. I'm just giving you sort of an overlay and landscape of, okay, what about up to getting a breast cancer diagnosis? What about when I have a breast cancer diagnosis? And what do we care about? And I'm a very data-driven person, so I need to know the facts. Okay. Oh, let's see if I can go here. And this just summarizes all the different studies that were in that meta-analysis, that Ballard-Barbash. So this is before diagnosis, after diagnosis, specifically looking at breast cancer death. Anything to the left of one would be good, and then all-cause death. Okay. So what are some of the recommendations and statements out there? So the American Cancer Society recommends women who've been diagnosed with breast cancer exercise about 5 hours a week to improve quality of life, as well as risk of developing new cancers. Research, as I have alluded to, shows that women who exercise at least 3 to 4 hours per week on an average pace, after being diagnosed with breast cancer might improve their chances of survival. Our NCCN guidelines recommend 150 minutes of exercise a week, and that's specifically shown here. Our National Comprehensive Cancer Network guidelines have probably presented these to you guys in terms of patients, and you can see here at least 150 minutes, moderate intensity, or 75 minutes vigorous intensity. You want to do some strength training, and then physical activity just for the routine stuff, like don't take the elevator, take the stairs, walk to the back of the parking lot. Don't, try and increase your activity. And these are the patient guidelines here. And these are really nice resources. All right, so Twin alluded to this, so I kind of put my money where my mouth is in terms of the power of exercise, but I want to make sure I understand the data, so I'm not just saying like, oh, exercise, great. Okay, why? Tell me why, show me the money. So this is the Lance Armstrong ride I did across the country with the Tour of Hope, and this was to raise awareness about clinical trials. It was a mixture of cancer survivors who were also participants, people who were doctors, nurses, out there in the community as well. And there was 26 of us that did this ride across country in a week, about 120 miles a day in 2 segments. stopping at several places. And for me, it culminated at NIH at the National Cancer Institute, which is where I first started doing cancer research when I was 18. So this really folds into my philosophy of care. So I believe in cancer survivorship, living strong, power of exercise, power of thinking. And really all of this is a crucial weapon to fight against cancer. So just so you know a little bit about me. All right, so what is exercise versus physical activity? So here are actually some of the definitions. Physical activity, any movement results in some energy expenditure above resting levels, okay? So that could be, easy stuff, walking to work, walking to the grocery store, even doing your activities of daily living, cleaning the house, doing some gardening, stuff like that. Versus exercise is a planned, structured, repetitive activity really to improve and maintain fitness, okay? So every Tuesday and Thursday, I'm going to go take the dog for a really brisk walk, and maybe I'll try and get a little bit of a jog in there to help my bone density. So these are sort of the differences. And again, here, I'm not expecting you guys to train for a marathon. I'm not expecting you to ride your bike across the United States. I couldn't do that anymore. That was like 15 years ago. But at any rate, like whatever you can do that you can work into your lifestyle, okay? No judgment here. This is just information, and do with it what you can. So I still had a lot of questions and like reviewing all this data. So what's the evidence of body weight and the impact specifically on physical activity or exercise in our cancer survivors? What are some of the interventions, and what are the effects on health outcomes? How can we apply what we do and don't to patient care? How can we deliver this? It's great that I can tell you to do all this, but how do you have the tools? How are you going to go outside? I mean, unfortunately, and this is just tragic, as an aside, I have Asian patients who are now afraid to go out and walk the dog in our beautiful city of San Francisco because they're worried about Asian hate crimes. How sad is that? So anyway, some of the challenges in delivering weight management, physical activity, and really want to focus on the quality of life aspect and symptom management. So I'm going to talk about reducing fatigue, arthralgias from the breast cancer pills, and really patient-centered care. So tailoring the interventions to the patient. And then how do we provide the tools? Physical therapy, occupational therapy, dietitians. So Twin talked about the community health services, which is downstairs in our Webster building. With the pandemic, most of this has all been virtual, but there are dietitians, there's even social workers, there's a whole psychosocial support team. So the phone number is on the door there, and she can also re-provide it at the end of the talk. But partnering with professionals who can help specifically looking at diet, exercise. There's also Dr. Demas has an MD weight management. I have some of those flyers in my office. That is a controlled calorie-based program with shakes and other types of physical activity. So those are the tools. And I like to say the 5 A's, which I think originally comes from smoking cessation, is, ask about it. Are you concerned about your weight? Tell me about your diet, advise, assess, assist, and then arrange for follow-up, okay? And then I said, other things that affect your overall health. What is your exercise ability? Are you going through a knee replacement? Maybe a stationary bike or swimming. I'll talk about some aerobic pool work, and smoking cessation I can't say enough about. So again, back to weight gain specifically in breast cancer survivors. So premature menopause leading to decreased metabolic rate, increased fatigue after primary treatment leads to decreased physical activity and weight gain. So it's sort of the dog chasing its tail, right? It's like, okay, maybe you're premenopausal and we gave you chemotherapy. Now you're postmenopausal, your metabolic rate's down, and it's really hard for you to lose weight. And now you have side effects from your treatment. And so it's really hard for you to get out there and exercise. So there's a lot of continued side effects and physical limitations, but there are late medical consequences in terms of heart problems, diabetes, etc. So going back to that WHI study, so I focused on sort of the weight aspect of things and how those patients in the study in 12 years of follow-up, the breast cancer incidence. Now this is really looking at those patients with invasive breast cancer and what was their physical activity at baseline, pre-diagnosis, and after diagnosis, assessed at a 3 or 6 year post-baseline visit. Is there an advantage to increasing physical activity after a breast cancer diagnosis, and especially women who were maybe inactive before diagnosis? And so here's the findings. Again, this is a lot of words, but the bottom line is, so women who had at least 3 hours a week of physical activity, so again, fast walking, there's METs, but you don't have to know what that means. It's more of a cardiology term. Before breast cancer had a lower all-cause mortality, probably related to heart and other side effects of obesity. And then women who had at least 3 hours after a breast cancer diagnosis also had decreased all-cause mortality. And then patients who actually increased or maintained physical activity after a diagnosis did decrease their all-cause mortality, even if they were sedentary before. So let's say you were not an active person, maybe you love video games or whatever, but then you get a breast cancer diagnosis or maybe any cancer diagnosis, and then afterwards you start to really work on your physical activity. That still makes a difference, okay? And this is just the schema for that. We already talked about all the patients in the Women's Health Initiative, and then who was eligible specifically in the breast cancer group, and what did they do. And so that's just the breakdown. And then this shows you too, in terms of who are the patients that are in that study. And I think this is important also to point out. Now, you guys, you signed up for this, you have a computer, you have internet, you have interest, you're probably pretty educated, and you care about this stuff. But that's not necessarily normal in terms of the population of everybody who gets cancer. So I just want to point that out in terms of the limitations of some of these studies. You know, so what I'm showing you here is that a lot of these patients were high school graduates. Typical, unfortunately, for the disparities we have in our clinical trials and research, not a lot of African American patients, predominantly white patients. And you can see here more estrogen positive patients, not a lot of current smokers, not a lot of current diabetics. So these are already motivated patients, okay? So just keeping that in mind. All right. And this data I already sort of presented in terms of breast cancer outcomes in the patients who had increased physical activity. You can see here that there is a decrease in mortality, okay? So a little over 40%, 41% age adjusted, and that's just the data. I don't expect you to understand that, but that's the net in terms of what that means, and I've already summarized that prior. So this is a little bit of a reality check. Again, I just wanted to talk about, well, this is great. You tell me all this stuff. I don't have a gym. I can't, the gyms are closed. There's a pandemic. I can't afford a gym, whatever. Or I'm afraid to walk my dog because somebody's going to hurt me. So, that's the extreme aspect of this, but this is just a call out to say, okay, this, aerobic exercise 3 or more hours a week has meaningful impacts on mortality and morbidity. Adherence will really require infrastructure. How are you supposed to do this? I don't want you to go out there and, try and bench press 200 pounds, or I don't even know what would be a lot. But you really need to say, not just do it, but how are you going to do it? So providing that infrastructure, and again, being acknowledging the ability, like, what kind of side effects do you have? Do you have neuropathy? Can you even hold things? And where are we going with this? So again, this is just another study that shows physical activity after a breast cancer diagnosis. So you can see the breakdown here in terms of hours per week. You want to get at least 3 or more hours, and you can see why. So the red is 3 hours. Doesn't really seem to do much in terms of breast cancer recurrence, death, or total death, all right? But when you start to then get more hours in, you see this has more impact. And so essentially the net here is 50% fewer cancer recurrences in women who exercised at least 3 hours a week. Okay. And this is just another meta-analysis summary of that. I think I've presented a lot of the data, but trying to harness this all together so it makes sense. So let's take a little bit of a shift. So I talked about the risk of getting cancer, and specifically breast cancer, in terms of a high body mass index. I talked about, well, what if you already have cancer? What can you do about it in terms of reducing your breast cancer recurrence risk and all-cause mortality from maybe heart disease or other stuff? Well, what about symptoms? Okay, so how can I feel better? What about my quality of life? So this is going to segue into some studies that specifically look at exercise and modalities in patients who have received or are receiving breast cancer treatment. So this is 32 randomized controlled trials, over 2,000 patients. There's different types of interventions in terms of aerobic, anaerobic. Some of them had strength resistance training as well. And this is during their adjuvant breast cancer therapy. So this could be a combination of anti-hormonal pills, maybe some prior chemotherapy, etc. And here's the Cochrane review. So again, a lot of different trials, 32 trials. Bottom line is improved physical fitness, breast cancer specific quality of life, cognitive function, muscle strength, and reduced fatigue, reduced lymphedema, and reduced mood disturbances. So that's the net. Fatigue is really the number one complaint. Cancer-related fatigue is often a disturbing complaint of people with cancer, can affect your relationships, can affect your productivity at work, your economic status, and your daily activities. And this is the American College of Sports Medicine, really roundtable on exercise guidelines for cancer survivors. But it can be managed, right? So fatigue can be managed. We talked about the NCCN guidelines of 150 cardiac type of exercise a week, the ASCO guidelines. And again, this is not training for a marathon. This could be a 30-minute walk. That can also be weight bearing for your bones if you have osteopenia or bone thinning, and about 5 days a week. And you can see the 16 trials that looked at this. 7 were during treatment, 9 were post-treatment. This was published in 2010. Bottom line, most studies showed a favorable effect of exercise on fatigue. This is another trial, the ENERGY trial, exercise and nutrition. It's a behavioral weight loss intervention in overweight or obese breast cancer survivors. So 2-year trial, almost 700 patients. Really the goal here was trying to watch your calories and do some moderate intensity exercise about an hour a day, looking at weight loss, quality of life, some biomarkers. And bottom line is in the intervention group, there was help in terms of physical function and vitality, and weight loss intervention really had the greatest impact at about 6 or so months later. And this was a 2-year trial. Okay. This is something I also want to highlight in terms of the Live Strong at the Y. When I was in Berkeley and Alta Bates, I created a relationship through the Live Strong program. So again, through the whole Lance Armstrong connection, Live Strong has been really great in terms of helping support cancer survivors. And so they had a grant to help cover YMCA gym memberships. And so I was able to refer my patients to the YMCA in downtown Berkeley. But this is actually a trial kind of looking at specifically quality of life, fatigue, in cancer survivors. What's also interesting here is this was sort of a blanket outreach. So letters were mailed to over 2,000 patients, and there was about 150 patients that were approached in clinic. But when you actually get down to how many actually participated, about 186. And, a lot of people not interested, maybe they live too far away, time doesn't work with their work schedule or kids pick up or whatever. no transportation. So again, some of the limitations you have to think about. You know, it's easy for me to say, oh, do this, but then how are you actually going to implement it? So they used this FACT-G, which was more of a quality of life type of questionnaire. And this was the fatigue. And the bottom line is in those almost 200 some patients, you know, the numbers are still small in terms of how many patients actually completed more than 20 sessions versus less than 20 sessions. But the difference here is basically showing you that if you could get about 20 some sessions in, your fatigue is better, that's the blue, and your quality of life scores are better, and that's the blue. Okay. And then again, you know, who participated in these studies? So Melinda Irwin, who's over at Yale, she was one of the investigators. You can see here that, you know, the patients who participated were from Harvard, Dana-Farber, or Yale, predominantly women, again, college educated, unfortunately, mostly Caucasian women who have the resources and ability to do this, non-Hispanic, and mostly breast cancer, but you did have some colon cancer and other patients. And for the most part, these were, you know, curative stage patients, 1, 2, 3. Okay. Well, what about other studies looking at aerobic and resistance? So this was just another study with 100 breast cancer survivors within 6 months of adjuvant treatment, either exercise or usual care. They had different baseline post-intervention follow-ups. And at post-intervention, the exercise group was superior in terms of the quality of life metrics, statistically significant kind of p-values with lots of zeros. They had better oxygen intake and overall muscle strength. So it's a pretty consistent message. Well, what about specifically some of those nasty arthritis joint symptoms that we experience in the anti-estrogen, specifically the aromatase inhibitors? So this was looking at several randomized controlled trials, over 2,000 women. I alluded to all this, but basically, you know, this can improve over time, and the study itself randomized to exercise or usual care. These are just some quality of life types of indexes and different scores of where you have pain in your joints. And then these patients attended resistance training sessions. Again, Melinda Irwin, she presented this in our oncology journal in 2015. And the bottom line is looking at a 12-month change in the pain score in the patients who are taking aromatase inhibitors. You want the pain to get better, so you want it to be in the negative. So you can see the exercise people had improvements in their pain, in severity, etc. So that's what's showing this, the change in the pain score. Whereas your controls who weren't exercising, you know, maybe it's getting worse, it's not getting better. All right. And then this sort of also looks here, this was a big trial looking specifically at anti-estrogens in breast cancer patients. And you can see here that patients who had a high BMI of over 30 had more joint symptoms, and that was significantly statistically significant. So more overweight on these breast cancer anti-estrogen pills, more stress on your knees, more stress on your hips. So that's kind of what that's displaying here. What about home walking programs specifically for pain in your joints from breast cancer medications? So again, this is more a self-directed walking program. Bottom line is the intervention group that did the walking had less perceived helplessness. They felt maybe more able to cope with what was going on in their lives. They were less helpless and feeling like they could manage their joint symptoms, improve stiffness, and improved activities of daily living. Yes, I can hold my coffee cup in the morning, and I can clean the windows, and I can grab the sponge and these sorts of things. And this just shows you kind of the different types of scores and outcomes. So not everybody can go out and walk. Again, I alluded to knee problems, knee replacements, these sorts of things. What about getting in a pool? So I think that I call the pool my mikvah. For me, it just cleans away the day and washes all the stress and worries away. So aquatic exercise in a chest high pool for hormone therapy induced pains in breast cancer survivors. So these were 40 women, pretty big age range, curative breast cancer stage 1 through 3. And they were allocated to either have aquatic exercise or usual care. So they did this 2-month therapy session with 24 sessions. This is sort of the breakdown in terms of the warm up. They had about 20 minutes of aerobic exercise, so kind of pool running, and then 20 minutes of recovery. These were some of the endpoints here. So looking at the pressure points, in addition to looking at cancer-related fatigue, waist circumference, and body mass index. Here are the results. Pretty good compliance. Almost 90% of the patients did all the sessions. Decrease in pressure pain, some decrease in waist circumference, and certainly in cancer-related fatigue. It's hard to know in terms of statistical significance for body mass index with 2 months in a pool. So what are some of the weight loss tips? Nutrition, I tell people, and I'm not a nutritionist, but the Community Health Resource Center does have nutritionists. Avoid white foods. So that's white sugar, white rice, white potatoes, crackers, bread, those sorts of things. Really avoid, modify intake of caloric beverages, sodas, wine, alcohol. Wine is basically kind of like grape juice or soda pop in the sense that, it's sugar. So if we've exceeded our caloric intake for the day, it basically goes into making fat. These agents, they spike blood sugar just like candy does, versus really more long-acting complex carbs, vegetables, things that are going to keep your insulin level more steady. How do you do this? I like the MyFitnessPal. I think that's a nice app that even has barcodes that you can scan. It gives you a little pie of how much fat, how much protein, how much carbohydrates. You can put your exercise in there too, even walking the dog, and it's all included. And just to point out that, it's not just about calories, okay? So you could, maybe restrict your calories to 1,000 calories a day. You might lose some weight, but if it's a muffin and, pasta and alcohol at night, that's very different than a well-balanced type of caloric diet. What about diet versus exercise? I think they go hand in hand as much as you can. It does seem that diet is a little more important. Exercise is also very important, but maybe a 60-40, 70-30 kind of ratio. And just to point out sort of how much work you have to do for that piece of pecan pie, so if you have a piece of pecan pie or a pumpkin scone at Starbucks, you're talking about probably 500 calories. Well, that's like an hour on the treadmill. And that's not necessarily walking, moderate pace. It's kind of picking up the pace and getting your heart rate at least above 100 or maybe, 120s, 130s. So think about it. And I think MyFitnessPal kind of makes you really, or any other app, there's many of them out there, makes you aware. A little caveat I can tell you guys. So with both of my children, I had pregnancy weight gain. And with my son, I think I stopped looking when I almost topped 200 pounds. And so then I was probably about 30 pounds from my pre-pregnancy weight. And so I was doing lots of walking with the jogging stroller and doing this MyFitnessPal business. And I remember I went to the city to get my hair done. Finally, I didn't have my hair done. It's kind of like the pandemic in a year or something at least. And so I went into a Starbucks, and it was, I think, around Halloween, and I got a pumpkin latte and a pumpkin scone, and I was hungry an hour and a half later, and I put it in MyFitnessPal at night, and it was like 1,000 calories. And so that taught me an interesting lesson about sort of, be careful what you eat, especially those processed foods. So going back to the 3 Ps in terms of palliation, prevention, health promotion, I think exercise certainly falls into this, watching your diet, body mass index, etc., and really impacts quality of life, medical outcomes. We've talked about recurrence risk of breast cancer and trying to decrease that. We talked about symptom management, the pain from the aromatase inhibitors and all these different things we can do to help that. Just to touch upon other things outside of breast cancer risk, I like to show this slide, and I teach our residents, and we now have a fellow. This is important in terms of high blood pressure. So, when you're overweight, your blood pressure can go up. The first thing we recommend for high blood pressure is diet and exercise before we start giving you pills. But I want to point out here, well, what's normal? So we always say, okay, 120 over, 60, 70 sort of being normal. Well, what this is showing you here is if you come into your doctor's office and your blood pressure is 135, some people might say, oh, that's not so bad. But look here, what is your risk for other cardiac events? So, optimal being down here, this is cardiac event. So that could be a heart attack. When you're at this normal range, you still have an incidence of cardiac events, and a 130 over 85, that's still considered high normal. And now you're increasing by 12, 15% your incidence of a heart attack or something down the road. So keeping that in mind. And then this is another slide that I use for our internal medicine residents. I said, intervene, don't let cardiac events get our cancer survivors because they survive cancer, right? So we talked about lifestyle modifications. If the goal blood pressure, you really want to have patients ideally more in the 120 over 60 or less. And these are, drug choices, but really diet and exercise is first line for a reason. So patient-centered survivorship, really taking care of yourself, empowering yourself, being aware of the short, medium, long-term effects of your cancer treatment. How can you take control of your life? How can you intervene? What can you control? You got cancer, that you can't change that. You can't go back in time. But now moving forward, how can you impact your own health and your own quality of life and maybe your risk of recurrence? And really work with your healthcare team, staying involved to really keep up the quality of your follow-up and the quality of your survivorship. And so I always like to present this slide too in terms of, not only is it a team, but it's all the facets of what a survivorship program looks at. So, not only is it physical therapy, exercise, it's support groups, it's smoking cessation, it's symptom management in young patients who haven't had children or want more children, fertility preservation, sexual health. The aromatase inhibitors and anti-estrogens can cause a lot of vaginal dryness and other stuff. There's a trial that I worked on in Berkeley looking at that question with Replens, non-estrogen types of methods versus Imvexy or other low dose types of interventions. And I always say that there's no taboo question. I ask patients about their sexual health, and that's a quality of life issue. So don't be afraid to ask your doctor or your team questions. So that's pretty much what I have in terms of the presentation. I know that was a lot of information, and it was sort of fun for me to kind of try and wrap my head around the data to know what's evidence-based and what's not. And we make these statements, but what are they grounded in, and what's the research that backs that up? So I think we have some comments here in the chat. And we've got some Q&A. So let's see, why don't I just sort of go down some of the questions here. So motivational support to start exercising. Yeah, that's hard. How do you get off the couch? It's a little paradoxical because I know that, when I wake up in the morning and I go for a 6 a.m. bike ride or whatever, I often have people that meet me. So getting buddies, and that could be dragging a partner out of bed, that could be an obligation to a dog, having other people that are waiting for you. I think that is motivation because you don't want to turn people down. I think, things like MyFitnessPal, where you can actually see some of your progress. Yeah, buddying up with people. I know that's hard now with the pandemic, obviously. It's not like you can just do meetups easily. But hopefully most of us are vaccinated and all you guys are vaccinated, and, outdoor stuff, maybe with your family, but set appointments, put it on the calendar. And start small. Again, this is not training for a half marathon. This is getting out the door. So that's kind of all I can say about that. Easiest ways to get back into exercising after chemo treatment, strategies for chemo brain, and remembering to exercise. So I forget stuff all the time too. What I do is I have my iPhone and it makes noises and I put it on the calendar. And again, I think having a buddy, somebody that's going to go with you. And I think just talking too, being outside, fresh air, not necessarily having music all the time. I like to just sort of listen to the noises and bring a friend or bring your partner and talk through the day, talk about the sunset, notice the trees, notice the leaves, take different walks around. There's a lot of books out there in terms of like Secret Staircases of San Francisco or Berkeley or wherever it is you live. Pick up some of those books and just explore. There's also some challenges out there. I know that East Bay Parks has a trail challenge. I think if you do 20 trails, you end up with a badge or something, but it gets you out there and you try different stuff. And there's, these are not 10-mile hikes. These are 2 to 4 miles. So I think in terms of the remembering, exercise also helps with chemo brain, and that's been studied. I think that's a whole different talk of, help, I'm in a brain fog. Okay, so weightlifting, super important. So I like to think about low weight, higher reps, so I do tell patients go out, walk with heavy hands. So 1 or 2 pound heavy hands. You can find those at Sports Basement or REI. There's also little gloves that you can wear that are about 2 pounds, or little ankle weights. Maybe start with that in terms of trying to get a little bit of weight on there in conjunction with your cardiac exercise. Simple stuff like seated squats. I don't recommend doing squats where you're pulling down on the bar because it's really hard on form unless you have a trainer that's working with you to make sure you don't injure your back. So it's little things. Again, this is not, Olympic type of squats and these sorts of things, maybe 10-pound weights, walking with 2-pound weights. That's the kind of stuff I would recommend. If you have injuries and exercise, what else can you do? So I'm not sure what your injuries are. I did allude to the pool. I think, you can run in the pool. And if you have access to a pool, I'm not sure which public pools are open at this point. It's usually just like a $5 or $7 fee. Are there exercise-friendly individuals with limited mobility? Yeah, so I think, again, pools, stationary bikes, if you can do that, so you're not really pounding as much. If you can get out of the saddle a little bit, that's somewhat weight-bearing. Pilates, other stuff. I mean, once gym's open, and if you happen to be a member, you can work with the trainer on something that can work for you. And I acknowledge that that's hard. Alcohol, how much is safe? Well, I didn't totally touch upon that, but the recommendations now are less than 7 in a week. So more than 6 is considered excessive. So, that could even be a glass of wine with dinner every day. So I try and say, okay, well, maybe when you go out to dinner, not necessarily, with every meal, or maybe on the weekends, Friday, Saturday, Sunday, however you can do that. I acknowledge the pandemic's hard. I acknowledge that we live in wine country areas and we have amazing wine. But at any rate, or, maybe it's a good glass of a Bordeaux or a Cab Franc instead of, 2 glasses of Pinot, something that's really kind of worth it. So it's moderation, whatever you can do. You mentioned gardening as a physical activity. What point basic physical to exercise? Yeah, so I think, I showed the definitions in terms of physical activity versus exercise. Getting out there, moving your body, trying to get your heart rate up. If you have an iWatch, it can measure your pulse. And there's also another app called Strava, Strava. It's a little orange app, and it can download onto your watch. So you can, just get an idea of, okay, well, I'm out there gardening. What does my heart rate do? So these sorts of things. And when does it wind? And it does wind me when I put myself to it. Okay. Yeah, I mean, I think in terms of other resources, the Livestrong website, American Cancer Society website, I alluded to some of the literature out there. I don't know if the Community Health Resource Center specifically has any guidelines. We do have a lot of physical therapists and occupational therapists. Some are focused on lymphedema, so Bettina and Sasha. But then there's proactive physical therapy. So, maybe kind of going that route in terms of maybe some structure. Yeah, Twin, I don't know if you can comment at all about other resources specifically available.
Along those lines, I'll check our resource library for anything related to physical exercise or physical activity, and I'll share it in the post-event email with everyone.
Okay. All right. Is there any other, can you advise the group on Signera? I guess why don't you ask me that question live, because I'm not exactly sure what you mean. Yes.
Hi. Yeah, I just I've recently found out about a new testing genome sequencing thing. It's called Signatera.
Okay.
It's been offered by a company in San Carlos called Natera, and what it's for post-cancer patients, and what they do is they request release of your tumor information, and they take a blood draw, and this is layperson speak. I think they can see if there are any similar DNA.
Yeah, it's looking. Sorry, I was expecting something related to exercise and recurrence.
No, it isn't. Not many people know about it, and I just think it's
let's talk about it. So there's different platforms out there. So there's something else called Clonosec, and we use this for looking for minimal residual disease. So little outside the scope of this talk, but let me just kind of address it. So for certain kinds of cancers, especially hematologic cancers, so lymphomas, leukemias, that type of stuff, we actually use MRD testing in terms of detecting earlier types of clinical recurrences, even if your bone marrow is clear, even if your blood tests are normal. And I think I saw one of my patients on that has been getting that done. So not really relevant to this conversation, but that's what it's looking for in terms of minimal residual disease. Now, I think what you're alluding to is more of, fear of recurrence and, is my cancer going to come back? And what can we do about that? So depending on what kind of cancer you have, your surveillance follow-up will be different. And part of the cancer survivorship program used to include and mandate what are called care plans, where it outlines your stage of your cancer and what your surveillance needs to be. And it's really different based on tumor type. So for example, colon cancer, lymph node positive colon cancer, after you've finished your treatment, then we do a CEA, cancer tumor marker blood tests, regular blood tests, and CT scans every 6 months for 5 years. Okay, so that's colon cancer follow-up. In terms of breast cancer and other types of cancers too, there's an ASCO Choose Wisely campaign that actually looked into what happens if you do surveillance, for example, for breast cancer. And it shows that tumor markers, which are blood tests like a CA2729 or a 15-3 in curative breast cancer, aren't necessarily helpful. Really, it's driven by physical exam, the routine blood tests, which include your complete blood count, your metabolic panel, which includes your kidney numbers, your liver numbers, physical exam. Sometimes it's been hard since we've been doing a lot of Zoom meetings, or not touching patients as much as we used to. And so that's like breast cancer follow-up. Now, there are other platforms out there looking at circulating tumor DNA, specifically like for high-risk patients. We have the Avatar study program. So some of my patients, for example, who are on preoperative breast cancer therapy, we check baseline for circulating tumor DNAs, and then followed by during the chemotherapy or the targeted therapy, and then continued follow-up even after they're done with all their therapy up to about 3 years to see, does that number go down if it was even detected at the beginning? And then if it comes back up, that might be a harbinger of recurrence. So that's sort of the data out there. So yeah, let's see. Now I have relapsing MS. Yeah, MS is hard. I mean, obviously, a lot of weakness issues. And then, thinking about a cold pool, that's probably not the best idea. There are some warm pools out there. I think there's one down in the Presidio, and I think there's over.
Dr. Dolezal.
Yeah.
I'm really sorry to interrupt. I'm going to read the question out loud for our participants who dialed in, and they may not see the questions.
Okay, no worries.
So this person asked, I have relapsing remitting multiple sclerosis. I am 69 and was diagnosed with stage 3 breast cancer. Any special programs or info you can help me point to? Also, if you are in the audience and you know these specific resources, feel free to put them in the chat and we'll announce them out loud.
Yeah, so not specific for your situation. I think that in terms of exercise, I think a warm pool might be something that's doable if you can find one that's open. First of all, they're hard to find, the warm pools. And second of all, are they even open? But maybe kind of working with your MS team in terms of what resources are out there.
I believe that was all the questions that we have. If you have any more, feel free to raise your hand. Raise your hand through Zoom, and that will let us know that you want to ask a question. Or you can do what we've been doing and type your question in the chat or Q&A. While you all are doing that, I just wanted to set a reminder that we have some really great upcoming nutrition classes. One of them is understanding your favorite groceries, and that's where a nutritionist will help you understand your nutrition label. This is an example of what many people still get wrong. One question that our dietitians often work with their patients on, one of the first ones, is how to read their nutrition label. This question here, what does serving size actually mean? Most people would answer C, but that's actually not the right answer. And we'd like to invite you to our class next Thursday to answer that question. And upon registering for this class, you're able to submit any particular favorite item that you buy from the grocery store that we can locate a nutrition label for, and we'll make a presentation out of it. So it's a really great class if you're wondering about the specific foods that you should be eating under certain conditions. I know that Dr. Dolezal mentioned that diet is a very big part in recovery. And if you have any health conditions that you'd like us to know about, and whether this particular ingredient or item that you buy is healthy for you, this is the perfect class for you. And then after that, the week after, we have chronic kidney disease and nutrition. This class is really relevant for anybody who has a family history of diabetes, hypertension. We'll touch on gout and itchiness even. This class is a 3-part class, and we'll also have a food demonstration at the end of the class series. So it's really exciting, and make sure that you come if you're available. Both of these classes will be on the coming Thursdays at 3:30, also on Zoom. And let me check for any more Q&A. Yes, we do have more Q&A.
Yeah, so I think in terms of the body mass index stuff, we looked at breast cancer recurrence risk. I think healthy lifestyle period, that's great that you're not overweight. Certainly we know from chemo brain, we know from arthritis side effects, from the aromatase inhibitors, neuropathy, getting blood in there. I often tell people to exercise barefoot on a stationary bike, or walk on a beach with no shoes and no socks. I think there's other health benefits, not just focusing on patients who are overweight post-diagnosis. 5-year benchmarks. Yeah, I mean, I think it depends on the cancer type. So I alluded to colon cancer surveillance, and the risk of recurrence is highest in the 3rd up to 3 years. And then in terms of year 4 and 5, it goes down to about 20 to 25%. So that's why I continue to do CT scans up to 5 years. But it's really so many variables go into that. So, is there a genetic syndrome, something like Lynch syndrome, non-polyposis cancer, breast cancer, if it's triple negative breast cancer, estrogen and progesterone and HER2 negative, yes, 3 years and certainly 5 years are a benchmark, because it's very rare for those tumors to recur later. Estrogen positive breast cancer, not necessarily. You might know that some of the earlier recommendations were for 5 years of tamoxifen, and there was no difference between sort of 5 years and 10 years at a little over 10 years of follow-up. But then when you went out to 20 years per the Atlas and Adams trials, you actually saw the absolute benefit was improved 20 years later, after 10 years after the 10-year people had finished. So I think it's, it really depends on kind of what kind of cancer you're talking about. What was the risk to begin with? Did you have lymph node positive disease? All these sorts of things. So I really can't answer that question. I'm curious what you guys thought about the presentation. Again, it was a challenge for me because I'm really evidence driven and I don't like to say stuff if I don't know the data. I acknowledge that it was pretty clinical. So I'm open to any feedback in terms of, what is useful in terms of medical literacy and that kind of stuff.
That's a perfect transition to, I'll share my screen again, to our feedback form. If you're able to, go ahead and scan that and a feedback form will open. But a feedback form will also automatically open if you are joining us on the webinar through your desktop, then a window will automatically open. let us know what you thought, and let us know if you have any more questions.
So I hope that gives you sort of a foundation and a building block to understand kind of what to do. And again, we're partnering with the Community Health Resource Center. They have all these supportive care services available, at least on Zoom and online like today. So reach out to them. Again, in terms of motivation, buddy up, be responsible and acknowledgeable of somebody else. That's kind of what gets me out of the door early in the morning before work, because I know somebody's sitting there in the cold waiting for me, or you have a dog looking at you that needs to be outside. Just baby steps as much as you can do. Okay, well, thank you, everybody.
Thank you so much, Dr. Dolezal. This has been a very sympathetic and informational presentation. I really liked how you thought about all of the challenging angles patients might go through during the recovery process. And thanks so much for the really great tips for getting up and exercising.
Yeah, and thanks to the Santa Rosa people for coming too. I think it's
definitely
great sort of reaching out across Sutter so we can harness more patients. That's one thing, a silver lining of the pandemic. I think as much as I like to see people in person, I think the outreach is so much better, provided that you have internet and a computer to do this kind of stuff, because you're really able to reach a lot more people across the whole, Bay Area and Northern California. So I think that's a nice thing about this stupid pandemic. All right, well, stay safe, everybody. Stay safe.